Hi there. My name is Shiba. Welcome to another podcast from We Talk Science. Thank you very much for joining us. Today I have Dr. Sarah Stutterheim from the University of Maastricht. Sarah, hi. Welcome to We Talk Science.
Thank you for having me.
Wonderful. Sarah, you and I, of course, know each other from a podcast that we did a while ago. But could you please tell us a little bit more about yourself?
All right, no problem. I'm an assistant professor of applied social psychology at Maastricht University in the Netherlands. And I do quite a bit of research on psychosocial aspects of HIV and on social stigma across a variety of identities and conditions that vary from mental health difficulties to LGBT communities and gender identity. Yeah, that's kind of what I do.
Excellent. Could you actually define, just for the basics of things, what is stigma? How do you scientifically define the word stigma?
Okay, so stigma is basically socially constructed. It's something that happens in interactions between people. And what it basically is a process whereby people are labeled and then devalued on the basis of a certain characteristic or an identity or a condition. And stigma can happen on multiple levels. So it's not only in the interpersonal level, the level that happens between people, but it can also happen on more structural levels and be evidenced in policy and legislation. It's also something that can be internalized. So if you internalize the negative beliefs about a given condition like HIV, then that is what we call self-stigma.
Interesting. So, what is the difference between, or at least maybe I should be asking, how would you define the interpersonal stigma versus the structural stigma and the internalized stigma?
Well, the interpersonal stigma that I spoke of is something that we call public stigma. So those are the cognitive representations, so the ideas that people have in their mind about another person, right? Basically, what you can imagine is that's what the general public or people out in society think about something, or think negatively about somebody with, for example, HIV, or somebody with mental health difficulties, or somebody that identifies as lesbian, gay, or transgender. The structural stigma is a product of those ideas that are out there in society, and it's what's embedded in our structures, in our institutions, in our ideologies. And the self stigma is what we bring into ourselves, the extent to which we believe those negative perceptions to be true.
So, you work with HIV, patients with HIV. Could you tell us a little bit more about what you do there?
Well, I've been working in the field of HIV since 2007. And my work in HIV is predominantly focused on social stigma and mostly on the experiences of people living with HIV themselves. But my work in HIV also extends to the entire treatment cascade. And even before that. So I've done work in HIV prevention in terms of testing. I do work on linkage to care. I've done work on treatment adherence. But across the board, all of that work has looked at the psychosocial aspects of living with HIV. And stigma is one of the big ones. In this day and age, people with HIV live long and healthy lives. If they're on their medication and virally suppressed, they're not in any way a threat to others in terms of being able to pass HIV on. But what people with HIV really still have to deal with is the negative responses from others to having HIV. So stigma remains kind of the core of my work because I think it's still the biggest issue being faced by people with HIV.
Could you tell us a little bit more about the psychological aspects, I should say, of people who do face social stigma?
Yeah,
How does
it's
it
not
manifest?
very good.
Well, yeah.
It's not particularly good. No, so there's a huge amount of literature that shows what the psychosocial impacts of stigmatization are. So in terms of psychological well-being, people who experience more stigma, or people who anticipate more stigma, or even people who internalize more stigma, they tend to experience more depression, more anxiety, lower self-esteem. On a social level, we see that stigma is strongly related to social support. And this relationship is not like a linear one in that sense. You know, if you experience more stigma, you're also less likely to disclose, and that's also less likely to access social support. And so social support and stigma, they kind of work together back and forth. Um, and we know that, anticipated stigma makes people wonder about whether or not they should be disclosing their status to others. And disclosure is always a choice, right? But disclosure does create opportunities to come into contact with others. And when we choose not to be open about our status because it's, for example, not safe to do so, then there's more likelihood for social isolation and greater disconnects with your social world. So those things play a role. And there are health impacts, of course, of stigma as well. Stigma and treatment adherence are strongly related. Stigma prevents people from getting tested and accessing care. Yeah, stigma in the healthcare sector itself, which is a bit of an issue, as an understatement. Also impedes access to other non-HIV care. So if you have the expectation that your dentist is going to double glove and schedule you at the end of the day, then you're probably less likely to give him or her a call to book an appointment. So yeah, there are quite a few impacts on a psychological level, a social level, and a health level.
It sounds like a really, really horrendous sort of vicious circle that these people who are stigmatized go into this vicious circle.
This is true, but there's also a lot of resilience out there. So, people who experience stigmatization also have agency, right? This in no way puts responsibility for stigma reduction on people living with HIV. But I think it's important to be cognizant of the fact that there's also been significant, over the past 40 years or so, significant resilience, empowerment, activism that has battled that stigma as well.
This leads very nicely into my next question, obviously. So, how do you counter this, right? So, I mean, obviously, could you elaborate a little bit more on this empowerment? How do we, what can governments do? What can the social structure do? What can, I don't know, agencies, like, for example, the GGD, the Public Health Service in the Netherlands, what role do all of these sort of different institutions have to ensure the safety or the psychological safety of these people?
Well, I think that really effective stigma reduction has to play into multiple levels. So we have to tackle, internalized stigma, public stigma, and structural stigma. And we have to do it with different targets. So you have to target those who stigmatize, and you can also work on developing resilience and empowerment in those that experience stigmatization or anticipate it. So like in terms of structures, policies that are non-discriminatory and are explicitly anti-stigma are really important. On an interpersonal level, there are lots of things that can be done. What we know with stigma is that stigma is not simply a matter of knowledge. It's not like if you tell people that about viral suppression and the fact that people simply can't get HIV if somebody is on medication, that's often not enough. We can tell people that if you're undetectable, you're untransmittable, that's basically it, but that isn't always enough. So what's necessary is that let me back up. When you come into contact with somebody that has a stigmatized condition, there's often a fear response, right? And this happens, the timeline is slightly different. So you have this initial fear response, and it might be corrected by a thought through, more deliberative response. And so if you correct that information, if you correct misinformation and myths, you'll be able to tackle that second part, that more deliberate thought through response. But it doesn't tackle the automatic fear responses there. And the only way to really tackle that automatic fear response is by creating opportunities for contact. So in the Netherlands, for example, where prevalence rates are relatively low, a lot of people have never actually come into contact with somebody living with HIV. And so they have all sorts of ideas about what that kind of person would be without actually having experienced that person in real life. And so creating opportunities for contact are really important because that really humanizes the experience. And that doesn't necessarily have to happen in person. You can also do that through vicarious contact or extended contact, as we call it, through digital storytelling, films, where it becomes evident that someone living with HIV is really no different than you or me or anyone else, right? So in that sense, you can play into that. And then in terms of internalized stigma, that's really about correcting the internalized negative beliefs. And so there are lots of more clinical psychological approaches that that work well: cognitive behavioral therapy, acceptance and commitment therapy, counseling, peer support groups. Those are all opportunities to reduce internalized stigma.
Do you have any examples of these initiatives that you have done to make people aware of and have people come in contact with somebody, for example, living with HIV? Is there a single example that you can give us?
Yeah, quite a few years back when we developed an intervention for reducing HIV-related stigma in the healthcare sector, we developed an online intervention, a website, where there was digital storytelling. There were short films of people living with HIV, talking about, what their life is, also talking about disclosure, non-disclosure. We also had films about, an interaction between someone with HIV and his dentist, and how that played out, and really made efforts in that to normalize these interactions. At the same time, not at the same time, but right now, my PhD student Yvonne van der Kooi, together with my colleague Arjen Bos and colleagues at Onze Lieve Vrouwengasthuis and Hello Gorgeous, we're developing an intervention for reducing self-stigma in people with HIV. And so this is a workshop-based approach where a group of people living with HIV come together to think about their experiences with stigma, how they've dealt with stigma, their own thoughts about having HIV, and through a series of exercises and discussions, hopefully they experience reductions in that internalized or self-stigma.
So let me see if I can phrase this next question correctly. We
Mhm.
talked about the situation in the Netherlands. In the panel discussion that we had earlier on World AIDS Day, which I will link to in the reference section later on, we spoke to a wonderful organization from Uganda where they talked about the effects of stigma in their communities against HIV positive people. However, it was surprising to me to hear that even in the Netherlands, the situation is still not as good as you would think, in spite of, us being
Mhm.
fairly tolerant here and all of this. And I'm not just talking about the Netherlands, right? I'm talking about various countries where, people can, or at least the impression is that people can live freely. So that was something that really surprised me. So I guess my question to you is, the stigma that we talk about, whether this initiatives that are doing in the Netherlands and all of this, how do you actually deal with stigma that is present in other parts of the world where, the concept of family, the concept of social norms are different. So how do you deal with those sort of disparities between levels of stigma?
I think one of the key things to realize here is that yes, cultures vary. Some are more individualist, some are more collectivist. In collectivist countries, there's fear of stigma by association, that, for example, family members will be stigmatized as a result of having a family member with HIV. But stigma is relatively ubiquitous. It's everywhere. And it's kind of like, I sometimes envision this as like a mixing board. We have these beliefs that underlie stigma. The beliefs are often that HIV is very contagious, that HIV is very severe, um, that HIV is the result of volitional behavior. So there's a perceived responsibility for the acquisition of HIV. And then HIV also has this reputation of being associated with a whole lot of behaviors that are perceived by some to be norm violating. So we've got sex work, promiscuity, drug use, men who have sex with men. These are all behaviors that I think, as you say, in conservative cultures are judged more than maybe would be the case here. And yet, across the board, there's stigma everywhere, and the mixing board might shift. You know, the ideas of norm violation might be lower here than they are, for example, in sub-Saharan Africa, but the stigma is still present. There's conservatism everywhere, and there's these beliefs that underlie stigma. They're present across the planet.
That's really interesting. So I come to this conclusion that stigma is a fairly universal human response.
Yeah, and it has an evolutionary basis. Stigma is it's initially there for a reason. Lincoln, Fellon, and Dovidio say that stigma basically has three functions. It's to keep people in, so it's about control, to keep people out, which often has been about disease avoidance, and to keep people down, which is about exploitation, right? And HIV is a medical condition. And so this notion of keeping people out is embedded in our biology. It doesn't make it functional in our day and age now where we are, but it has an evolutionary basis. So yeah, it's universal.
Well, I like to think that, you know, empathy is also a very universal human trait. So
It is, and empathy is one of the #1 ways to tackle stigma. If we can induce empathy, if we can encourage people to take the perspective of the other, it makes a huge difference. Like some stigma out there is really blatant and explicit, but a lot of stigma is unintentional. So a lot of people, you know, that have a fear response don't intentionally mean to have a fear response, but they just have it, right? And so taking the perspective of another person into account is really important. I think this is across the board for all, you know, human interactions. It's really important to think about what something is for another, right? But when we talk about stigma reduction, one of the key tactics or methods that we use is perspective taking. When you think about what the impact of a stigmatizing experience would be for somebody who experiences that. And this often has the capacity to change that behavior.
wonderful. Well, then empathy solves quite a few problems, I would say then.
I think we need a lot more empathy in the world. I think it would make a huge difference.
I'm right there along with you, honestly.
Yeah, yeah.
So when we were talking earlier, we were also talking about the evolution of terminology and I guess language when it comes to different sort of people. Could you elaborate a little bit more on that?
Yeah, particularly in the context of stigma, language is really important. And I'm going to divert from stigma here to COVID because this is where we see this language having a huge impact as well. Language has the capacity to generate fear and it has the capacity to generate judgment. So when we talk about, there's so many lessons to be learned from HIV and how we approach the COVID-19 pandemic, right? But when we talk about the kinds of words that we're using, they're really powerful. We don't talk about catching HIV, but we do talk about catching COVID or getting, you know, spreading COVID. Spreading as a word or spreading HIV has an attribution of blame embedded in it. And so I think it's really important to think about the terms that we're using. Even when we talk about in terms of HIV prevention, we often talk about risk groups. It's, you know, they're putting people in a box, it's categorizing people. And yes, I understand the value and function of these terms, but at the same time, it's really important that we make sure that the words that we use are non-stigmatizing. So we don't talk about catching or spreading. We don't talk in terms of anything that would attribute blame. We don't talk in terms of things that generate fear. In the context of COVID, we're now talking about all these variants, the British variant, the South African variant. This isn't very helpful because it labels a part of the world and the people that are from that part of the world. And we've seen this in HIV over the world as terminology has evolved over time to be much more inclusive, much broader, and to be less stigmatizing. So we used to talk about HIV positive people or HIV positives. We now talk about people with HIV because HIV is only one part of somebody's being, only one part of their identity if they see HIV as being part of their identity. They're not fully defined by having HIV. So in that sense, I think that terminology is really important. Our words are powerful.
Indeed. So it occurs to me that, what you mentioned about the negative connotation of the word spreading, for example, or HIV positive, or, these sort of terminology that we use. I learned something new, right? So I didn't know that, language should be, or at least, when it comes to HIV positive, that, people don't really quite say that anymore because it is this negative connotation. So my question to you is, how can we make sure that we are using the correct terminology? And I mean, what is the media doing in all of this?
Yeah, that's interesting. Your question's actually two-part here. The media, and I'll come back to the media in a minute, but your first question was, how can we make sure that we're navigating this correctly and using the right terms? I think it's really simple. You got to ask the people to whom it pertains. So if you're curious to know what kind of terminology is fitting in this day and age, you ask people with HIV what terminology is fitting. And for example, the HIV Association here in the Netherlands has a media guide for the kinds of words to be using. And this also applies for COVID. They exist as well, these kinds of terms. And you're pointing to the media, and their role in this is really important in light of some recent data that I have that showed that over the past 5 years, people with HIV in the Netherlands, let me back up. We asked people to report on stigmatizing experiences across a number of different settings and contexts, one of which was media. And among the respondents that we had, 70% had said that in the past 5 years, they have heard stigmatizing messages in media, which means that we really need to do some work in media in terms of doing that. And this is, again, a situation in which I think that this is often inadvertent and often a matter of not knowing what kind of terminology could be perceived as hurtful. And it comes back to this thing of asking the people to whom it pertains how they want to be spoken about. And I think there's a lot of possibilities for developing better relationships between those who make news, journalists, and academics and civil society organizations. When we build these kinds of relationships, we have the potential to create better media that isn't stigmatizing.
One last question for you, Sarah. So, when we talk about media and how to make sure that you are saying the right thing, as I understood from you, terminology can be geographically dependent. So, in different countries,
Mm-hmm.
different places, you have different ways of saying things and different terminology. How do you navigate that maze?
I think you just ask.
Oh, yeah.
You just ask locally what the relevant terminology is. Of course, in international literature, it's usually English, right? There's terminology in the Western world, I think, is pretty much across the board. What I also find interesting is that terminology evolves over time, but there are local differences. And we even see this in terms of stepping away from HIV. In English, we don't really talk about homosexuals. It's not an appropriate term in English, but it is, for example, in Dutch. And so you see how this kind of varies. But it comes back to, again, simply asking people what fits for them. And it's, again, that kind of like taking an empathic approach, taking an approach of wanting to learn and taking the perspective of the other person to better navigate that space. I think there's a lot to be said for a kind of humility in how we do these things and simply asking when we don't know.
Wonderful. Sarah, that was so educational. I learned so much from you. Thank you so much.
Thank you very much.
And thank you all also for listening. And till the next time, this is We Talk Science signing out.